I'm Jessica Shank. Thank you guys for coming today to listen to me talk. This is a tough act to follow, Dr. Cowan and Dr. Ayumeng, because they are amazing women that I am so honored to be colleagues with here in Louisiana to take care of women with female pelvic cancers. I truly thank Dr. Amy Jernigan and Mr. Chad Landry for inviting me to speak to you guys today. And I really thank all of you who are here in this room that show an interest in our small little field of oncology. Even though it's small, it's very important, as both of the previous speakers discussed, on how important female pelvic cancers are on the lives of women here in Louisiana. Today, I'm going to talk a little bit about cervical cancer and ways to prevent it. And then at the end, we're going to talk about, well, throughout the talk, we're going to talk about emerging threats and hopefully come up with some innovative solutions for women here in Louisiana and cervix cancer. I have no disclosures, but I will disclose I'm not a paid speaker by Merck, but I have used some of Merck's slides here in this talk. So just a little background on cervical cancer. It's the fourth most common cancer in women worldwide. It originates in the ecto and endocervical mucosa in the transformation zone. And this is an area on your cervix, which is an area of transition. So it's basically where the flat squamous cells of the ectocervix meet the glandular cells of the endocervix. And as you go through the menstrual cycle and you go through your life, that transformation zone actually changes. And so we call it an area of metaplasia. And because it's constantly undergoing change, it's actually highly susceptible to the HPV virus and to mutations in that area. Cervical cancer is actually caused by a persistent infection of the lower genital tract by one of 15 high-risk HPV subtypes. And greater than 80% of women will acquire HPV infection in their lifetime. Only about 1 in 10 of these will become persistent infection. And of the ones that are at high risk, most commonly it's going to be HPV 16 and 18, which will account for 71% of cervical cancers in the US. And these other types account for the rest. So really, when we talk about advocacy for our patients, we really want to talk about prevention. And so there are two ways that we prevent cervical cancer here in the world. Number one is HPV vaccination, and number two is screening for precancerous lesions, meaning we identify abnormal cells on the cervix or other parts of the body, and we actually remove them before they're allowed to become a cancer. Dr. Jernigan mentioned this on her slides about the World Health Organization Global Initiative for the Elimination of Cervical Cancer. And it's a 90-70-90 triple pillar intervention, and it's to be done before the year 2030. And the goal is to have 90% of people fully vaccinated with 2 doses of HPV vaccine by age 15. 70% of women being screened using a high-performance screening test at age 35 and 45 years old, and 90% of women with cervical lesions to receive treatment. And so that is our goal. I'll tell you that cervical cancer is actually 100% preventable, meaning no woman in the world should actually get cervical cancer because we have these 2 options. My sister decided to leave the United States and move to Australia when she went there for graduate school, and then married an Australian man and never came back again, except for Jazz Fest and Mardi Gras sometimes. And in Australia, they've actually cured cervical cancer. It doesn't actually exist in that country anymore. And part of that's because they have socialized medicine where everybody gets vaccinated and everyone gets screened. So I just want to talk a little bit about HPV-related cancers and kind of where you live, and also about prevention. And so what I'd like to say is that HPV actually doesn't just affect women. It actually affects all people in this room, so men and women. And I'm going to get into that in a little bit. So geographic location is important. So we talk about our environment, and we talk about our neighborhood and the impact on our health and our well-being, and those influences on how we seek care and how we have access to care. So I'm going to talk about the geographic variability of HPV cancers. So if we look at cervical cancer screening in the United States in 2020, you see that on average, our healthy people goal is 79%. Our current national rate is 77%. And we look at Louisiana, and we're actually below the national rate. So we're not doing very well as far as screening goes here in Louisiana. And then we go and we look at actually the rates of new cervical cancer. And, our national rate is 6.8 cancers And if you look at our Louisiana here, we're below that. And so we are not actually, we are actually have worse cancer, we have more cancer diagnoses than many of the other states in the United States. And this is why everyone in the room should pay attention. And I'm speaking to all the people who have XY chromosomes, no matter what gender you identify as. There's actually, we have a high rate of new oropharyngeal cancers in males. So the rate is 17.1 per 100,000 men. But if you look at Louisiana, we're above that. And so we're not doing well in that realm either. And if we look at the rate of increase from 1999 to 2015, the oropharyngeal cancers rates in males surpassed cervical cancer rates, and as well as anal cancer rates. So if you look at that orange line right there, that is the oropharyngeal rate of cancer in males. So, and you see that that is actually on the increase, whereas our cervical cancer rates are actually decreasing, and the rest are down there below. Our more rare cancers are pretty stable. And if we look at when we look at men versus women, we see that men actually have 5 times higher rate of getting an oropharyngeal cancer that's HPV related. And so when I talk about oropharyngeal cancers, I'm talking about cancers of the mouth, the throat, the larynx, and I'll show you a little bit about that. So we have 10,500 men cases per year of the 12,600 cases per year. So pretty high as far as men goes. So men, I want you guys to listen. I want you to think about what I'm saying today and think about what you can take home from this, which I'm going to get to later, which is this, the HPV anti-cancer vaccine. And the reason I call this, or we call this, an anti-cancer vaccine is historically it's been associated with sexually transmitted infection. And yes, HPV can be transmitted sexually, but it also can be transmitted orally as well, which is why we see oropharyngeal cancers. And so I think the uptake of the HPV vaccine initially was, parents were like, well, my child's not ever going to have sex until they're married, and they're only going to have one partner, and that's it. And obviously we know that's not true, but HPV is more than that. It's not just a sexually transmitted infection. And so you can get HPV from any oral contact, any genital contact. A condom is not going to prevent you from getting HPV, and it's universally pervasive. So just a little bit about the virus. So the prevalence peaks at 25% of women younger than age 25, meaning that we see that women are getting the virus after their sexual debut. This virus actually was launched in 2006, and it's a recombinant vaccine composed of virus-like particles of the capsid that surrounds the viral DNA. And it's not infectious because it doesn't actually contain the viral DNA. What the scientists did is they took the shell around the virus, or the DNA, which is inside the shell, and they took it and made pieces out of it. And they used those pieces to generate an immune response against the virus. So the virus is the human papillomavirus 9-valent vaccine, also known as Gardasil 9. It's indicated for women that are females 9 to 45 years old, and it's for the prevention of all these different lesions, including cancers, as well as indicated for males for all of these reasons, which are cancers. And so I think there's a huge misunderstanding in our culture that men don't need the HPV vaccine, even though it is FDA approved for all of these people. I will tell you a story today. My second-year resident in clinic told me that he tried to get his primary care doctor and 2 different doctors to prescribe him the HPV vaccine, and both of them said no, they would not do it because they were uncomfortable. And they're speaking to an OBGYN resident here. Like, this is somebody with knowledge who also prescribes this vaccine. So I just said, why don't you get one of your fellow residents to prescribe it to you? Because you definitely need it. And so there's a lot of providers that just don't realize that they should be giving this to men and women. So the good news is if you're younger, meaning age 9 to 14, you only have to get 2 shots. So you get one at the first day, and then you get the second one anywhere from 6 to 12 months later. Once you get beyond 15 and older, then we recommend 3 shots, and that's time 0 at the 2-month mark, and then also at the 6-month mark. But what we know about the HPV vaccine is that 3 doses are best, right? But you still get protection with 2 doses, and you still get protection with 1 dose. So even if you just get 1 dose in your patient, you're actually helping them. So this is a picture of the anatomic locations in the head and neck. So this was a study where they swabbed patients with, or they actually took tumor registry archival tissue of cancers, and they tested them to see if they were HPV positive, and they found that 70% of the oropharyngeal cancers were HPV positive. In the oral cavity, it was 32%, and in the larynx, it's 21%. Now, just because these numbers aren't 100% does not mean that there aren't more cancers caused by HPV in this area. At some point, when a tumor gets too mutated, it loses that virus and you may not detect it anymore. So it still could have been caused by HPV, even though they didn't pick up the virus here. So let's talk about vaccination rates among adolescents. So this is an estimate. This was the NIS teen survey study, and basically they were looking at vaccination rates in this data set based on their insurance coverage. And if you look, it goes from 2015 to 2022, and you look that the only line that continues to increase is private insurance, and unfortunately, any Medicaid is actually starting to decrease, and uninsured obviously is also decreasing. And so, unfortunately, probably since the COVID pandemic and lots of vaccine hesitancy, the HPV rate of vaccination is also going down. So this same study, they're basically estimating what percentage of adolescents are up to date with either the 2 or 3 dose series. So by age 13, it's 50%, and by 17, it's 68%, and nationally for the whole group, it's 62.6%. So obviously, we're not doing very well, especially if our goal is to get to 90%. We're barely 2/3 of the way there. And unfortunately, in this slide, you see that other vaccines are still being given at the same age group, but for whatever reason, we're giving Tdap, we're giving meningitis, but we're not giving HPV. And it's unclear to me why this is a conversation. Every time I go into my pediatrician's office, I have 2 daughters, one's 10, one's 15. I've had this conversation with both of them, and I had to convince my pediatrician that it's okay to vaccinate my 10-year-old for HPV, even though it's on the 11-year-old schedule. That I was getting pushback for. So, and I was like, I'm sorry, I take care of cervix cancer. I see women die regularly from this cancer. I would like this vaccine today. And I had to really push back to get my 10-year-old vaccinated. So unfortunately, it is an issue in the pediatric spaces. And part of what I think is going on is, nobody asked you if you wanted Tdap and told you what Tdap stood for. Nobody asked you if you wanted this combo meningococcal virus and explained to you what it is. But for whatever reason, we have to have a conversation about HPV vaccine and what it means and how you get it. Really, what it should be is, these are the vaccines, these are the information that you can take home and read about it, and you have the opportunity to accept or decline them. And leave it at that, and let the patients, read and understand. But what's happening is that patients are asking to opt in to HPV vaccines instead of asked to opt out. And so that's sort of the difference that's occurring in this age group here. So if you look at the geographic variability, you'll see here in Louisiana, still we're kind of right below that national average. And unfortunately, in Louisiana, and I know that Drs. Cowan, Jernigan, and Ayman can attest to this, we see very aggressive HPV here in Louisiana. And we see HPV cancers that should have taken 5 to 10 years to develop. And we see patients that had Pap tests that were normal 2 years ago, and now they have a 3B cervix cancer. And so for whatever reason, we have very aggressive cervical cancers here in Louisiana. And so we need to be more aggressive about how we prevent them. This is similar to the slide I showed earlier. And then this is looking at the adolescent up to date, and still we're still behind the curve in every measurement. And then this is looking at urban areas, and if you look, the black areas where you're living closest to an urban area, and the green, the lighter green and the other green show that the further you get away from an urban area, the less likely you're going to be up to date on your vaccines. So when we say Louisiana has a big rural population, these are the people that are missing this vaccination opportunity. So now let's talk about older people, so 18 to 26 and the 27 to 45. The reason it's separated like that is because initially when it was FDA approved, it was FDA approved up to age 26, and it was actually just for women. And then the FDA got smart and realized we need, women are not the only people that get HPV. It's takes two to tango. And so they gave it to men too. And then ultimately, as the data got better, we realized there's actually a benefit to giving it even after people have been exposed. So the age 27 was based on, hey, let's vaccinate people before they've been exposed to the virus, meaning before they have sexual intercourse. Now we have lots of good data to say that even if you've had high-grade dysplasia, you've had an excisional procedure to prevent your cancer, you actually have decreased recurrence of high-grade dysplasia if you get vaccinated after that. So if your doc says, no, you don't need it, you already have HPV, that's absolutely wrong. You're the one who needs it the most. So these are vaccination rates in this older age group, 19 to 26-year-olds. And here you see 53% of females and only 26% of males are getting vaccinated. And that just means they got at least one dose. And then this is a different study also looking at the same cohort of patients, and this one was published in 2022, and it shows that we're doing a little better than the 2018 study, but still not good enough, 57% and 37%. And then this is looking at a different group, and so basically what it is showing is that 85% of adults, this is looking at the older population, so 27 to 45, and 85% of them were never vaccinated, and that was in 2019. Now I'll tell you that the age that it was expanded was in 2018, so it doesn't surprise me that this data is so terrible, so we definitely need to look at this data again and see how much progress we've made since that expansion by the FDA. And so these are the three studies kind of next to each other, sort of showing the vaccination rates. And so in the teen study, it shows that in the 17 age cohort, 20% were never vaccinated. And then in the 2022 study, it shows that in the 18 to 26 group, 63% of men and 43% of women were never vaccinated. And then in the 2019 study, they show that 27 to 45-year-olds, 85% were never vaccinated. So this is just kind of looking at those three studies next to each other. So we want to talk about implementation of HPV vaccine. And so this is where I think, in the state of Louisiana, unfortunately, we have a lot of barriers to care, whether it be you live in a rural area, your socioeconomic status, the beliefs of your community, the beliefs of your family, the beliefs of your healthcare providers. But unfortunately, in Louisiana, as of February 13th, 2025, the Louisiana Department of Health has ended all vaccine events and instructed staff to not encourage immunizations. And this was an internal memo sent to the Louisiana Department of Health by the Surgeon General, Dr. Ralph Abraham. And basically what the conversation is that rather than instructing individuals to receive any and all vaccines, the LDH staff should communicate data regarding the reduced risk of disease, hospitalization, and death associated with the vaccine, and encourage individuals to discuss considerations for vaccination with their healthcare provider. And the department has ended all mass vaccination programs and ended vaccine clinics. And basically directed them to use language with a new focus on meeting people where they are, which unfortunately leads to a lot of confusion and uncertainty among our patients. And so although I don't disagree that vaccination should be a conversation between a patient and their provider, I do think it's something that should be universally offered. And the language to say that we should to pull back on Louisiana and not have these universal vaccine clinics is going to affect all of the children here in Louisiana. And we're going to be at very high risk for diseases that we haven't seen in years. And so, I believe in the role of physicians and their patients and that relationship. But a lot of our patients aren't insured. They don't see healthcare providers, and sometimes these vaccine drives are the only opportunity these patients have to get vaccinated. So these are some suggested strategies for vaccine implementation in rural settings. And so, you know, I have a medical student who's did a research project this year who she basically sent out a survey to a bunch of primary care, family practice, and OBGYN providers to talk about barriers, or do they give vaccines and what are the barriers? And I would say the number one comment was about barriers to vaccines. And a lot of it is that these docs don't have the HPV vaccine in their clinic. And we know that if you can get the vaccine right then and there, patients are more likely to get it as opposed to having to go to Walgreens and go to their minute clinic and get the shot there and then remember to go back in 2 months and then again in 6 months. And so, our next project for this student is to actually call all of the internal medicine, family practice, and OB/GYN offices and query whether they offer or advise patients to get the vaccine, but then also do they offer it in their clinic, and see where we are as far as who doesn't have it in their clinic and who does, and how can we do better there. And then following that, I'm going to get Merck to help me put these vaccines in every clinic if we can. So just to summarize, where you live does matter. And Louisiana, we struggle here with a lot of things in healthcare, and this is an easy fix that we should be able to do. I'm going to talk a little bit further about cervical cancer screening because this is also the second part of this tool in preventing cervical cancer. And it's just as important as HPV vaccine. Unfortunately, as many women in this room know, cervical cancer screening is not pleasant. It means that you have to go to see a doctor, you have to get a pelvic exam, you have to put your feet in these things called stirrups. How many men in this room have put their feet in stirrups on an exam table? Dr. Hamilton has. And it's probably just to see if he knew what his patients were going through. So, and women have to have a speculum exam. How many men have had a speculum placed anywhere in their body, right? And so it's not easy. We take it for granted because as physicians, we're like, oh, just go get your pap smear. But you have to think about what that means. That means you have to take off time from work. You got to drive to the clinic. You got to find parking. You got to go in. You have to meet with the MA, meet with the nurse, and then you get to see the doctor for maybe 5 minutes if you're lucky. And in that 5 minutes, you're literally sitting on a table naked and putting your feet in stirrups and having something inserted in your vagina. It's not the best way to do this, but it is what we have to go through. And so that's why we need to use both the vaccine and screening. So there's lots of different ways to screen for cervical cancer, and I think we're actually making advances in this realm as well. So initially we had what's called cytology, which is the pap smear. And basically what that means is you're in those stirrups, the speculum's in the vagina, and we are scraping cells off your cervix. How fun does that sound? Now we have what's called liquid-based cytology. Same procedure, but it's a better test because we can put it in liquid. We look at the cells, see if they're abnormal, but we also do HPV testing. And we know that HPV testing actually is a better screening tool. So the next option is HPV-based screening, and this is something that we're going to move toward because it has a higher sensitivity and accuracy, and it's more reproducible compared to liquid-based cytology. It has a better negative predictive value, and what that means is if you're HPV negative, your risk of having dysplasia or high-grade changes on your cervix is extremely low, if not almost zero. And so to be HPV negative is what we all want to be when we leave the gynecologist's office. So a lot of healthcare systems are actually switching to primary HPV screening where you still do the same procedure, you do the pap smear, but you don't actually look at the cells, you do HPV testing, and if it's positive, then you look at the cells. So it decreases how many pap smears have to be read. And the Europeans are already ahead of us on this. As far as low resource areas, you can do screening. So for anyone who's done medical mission trips, when you go to low resource areas, you basically perform an exam, and instead of doing the pap smear, you just put 3% acetic acid on the cervix, which is the same thing as household white vinegar. You look at the cervix, and if you see any area, you actually will biopsy it or just remove it. And then there's also the single visit approach, and that's where you basically you see it and you treat it all at the same thing, all at the same time, and that's also done in low resource areas. Something that's new on the horizon that the OBGYNs and primary care doctors who do Pap testing are going to see come in the future is something called the P16 Ki67 dual stain. And basically what this is it's for our patients that are HPV positive, and it's not high risk 16-18, but the other high risk types, but their Pap is normal. And you bring them back the next year and you do the same tests and they're still HPV positive, but their Pap is normal. And you bring them back again and it's positive, but their Pap's normal. Who of that group of people could we say, you clearly have HPV, it's not doing anything to your cervix. Maybe we don't have to do your colposcopy or biopsies or all of these other procedures that are pretty invasive and uncomfortable for women. And so P16 is a marker of HPV oncogene activity, and Ki67 is a marker of proliferation, which is what we know abnormal cells will do. And so if you see these dual stain positive, those are the people that you say, okay, let's go into colposcopy, which is the next step in the treatment for dysplasia. But if the dual stain's negative, then they can follow up in a year and not have to undergo a colposcopy. If you're HPV 16 or 18, that's basically cancer in your cervix till proven otherwise. And I will tell you how many, I have treated, and I'm sure the other GYN-oncologists in the room have seen women who were Pap normal, HPV 16 positive or HPV 18 positive, and they had a cancer. So you cannot just do a Pap smear anymore. So those people will get colposcopy no matter what. So basically, this is sort of the algorithm. You get your HPV screening. We type it. If it's 16 or 18, you're getting a colposcopy no matter what, because we're trying to find that cancer. If you're one of the other high-risk types, then we look at the cytology and decide if it looks abnormal or not. If you're negative, you can go back to routine screening. At this point, if you're over 30 and you get a HPV test that's negative, you actually don't have to have another test for 5 years. And so that's really nice for women who don't like having their cervix scraped every time they see their OBGYN. Just to talk about the next step, so after you get your colposcopy, if you do have a biopsy that shows high-grade dysplasia, meaning your cells are starting to mutate, they're starting to look ugly, they're not quite cancer yet, but these have a higher risk of becoming a cancer as opposed to being cleared by your body's own immune system, then you undergo a procedure called a LEAP or a cold knife cone. So the LEAP is the picture on the left, which is just a hot wire where we do a bigger biopsy of the cervix. And then the cone is you do the same thing, but that's performed in the operating room under anesthesia, and that's using a knife or a scalpel to cut out a bigger biopsy on the cervix. And the goal for this procedure is actually twofold. One, it's diagnostic, meaning we want to make sure, hey, do you still have that high-grade dysplasia? And B, is it a cancer? Because we want to catch it early, right? So we can treat it early. But it's also therapeutic, meaning we're removing all those abnormal cells that have started to mutate in your cervix. And the goal is to actually remove the entire transformation zone, which is that area of metaplasia that I talked about earlier. So in summary, I have two main points here. Men and women between 9 and 45 should all be vaccinated with HPV to prevent multiple cancer types, and women should undergo cervical cancer screening starting at age 21. So when we talk about emerging threats, I think our biggest emerging threat right now is vaccine hesitancy, which I understand after the COVID pandemic. There was a lot of discussion of vaccines and were they safe, and a lot of information that may be true, partially true, or not true at all. And it's really hard to sort through all of that and figure out what's right and what's not. But this is not a vaccine so you don't get the flu or you don't get, a COVID infection, which may or might not be very severe at this point in time. This is a vaccine that's going to prevent your cancer. And so the innovative solution is the people in this room and this organization called CAGLA. We need to go to the state legislator and say, this is an anti-cancer vaccine. This should not be optional. This should be offered to every single person in this age group here in the state of Louisiana. And then when we get it passed in Louisiana, we're going to go to the United States Congress and get it passed there. So I am done. Happy to take any questions.